Welcome to the Cardiac MR Learner Series, a unique video tutorial program under the aegis of Indian Association of Cardiac Imaging. This program is focused on beginners and intermediate images with learning happening through short sessions and case-based discussions. We are grateful to experts from different parts of India who have helped us in putting this program together. Please do feel free to give us your feedback so we can continually improve such training opportunities. This session is brought to you by Dr. Onkar Auti from Ruby Hall Clinic, Pune. He is a consultant radiologist with special interest in cardiac imaging. He finished his fellowship training for Level 3 certification by the European Association of Cardiovascular Imaging and has published more than 7 articles in peer-reviewed journal and has written a few textbook chapters related to cardiac imaging. He is also an executive committee member of the Indian Association of Cardiac Imaging and has delivered multiple talks in national and international conferences.
Hello everyone, I am Dr. Onkar Auti and I am going to discuss CMR assessment in congenital heart disease part 1. Why we are doing cardiac MR in congenital heart diseases? As we know, the cardiac MR is multiplanar imaging and has a very high spatial resolution in cardiac imaging. So it gives us a very good anatomical details in congenital heart diseases. Cardiac MR is gold standard for the LV and RV function, and the functional assessment is of prime importance in management of congenital heart diseases. With the help of phase contrast imaging in cardiac MR, we can determine the blood flow and hemodynamics in the congenital heart diseases. Usual indication: corrected cases of Tetralogy of Fallot, Ebstein's anomaly, and complex congenital heart diseases. What we are going to discuss in this topic is what is the basic protocol for congenital heart disease, what should be the basic approach towards the congenital heart disease on cardiac MRI, cardiac MR assessment in cases of TOF and Ebstein's anomaly. For the basic cardiac MR protocol in congenital heart diseases, we start with the localizes, then the black blood and white blood static images covering the chest. The most important sequences in the cardiac MR protocol are the cine stacks acquired in the standard axial and coronal planes. Then the particular cine images across the 2-chamber view, 4-chamber and the 3-chamber view are acquired. The LVOT and the RVOT view. The phase contrast imaging is acquired in through plane of aorta and MPA, and if required, RPA and LPA. The contrast angiography really helps when we are going to assess the smaller vessels or the collaterals. Towards the basic approach to any congenital heart diseases, it is very easier if we follow the blood pattern, that how the blood flows into the heart. Let's go from the left innominate vein. You can see this is the left innominate vein, which further drains into the SVC. If we follow the SVC inferiorly, the SVC should drain into the right atrium, and if we follow the right atrium inferiorly, you can see the IVC is draining into the right atrium. Make sure that there is no interruption of IVC. Then the right atrium drains into the right ventricle, and the right ventricle gives rise to MPA, and this is the RVOT. This is the main pulmonary artery which divides further into the RPA and LPA. So then blood goes into the lungs and it comes back to the heart via pulmonary veins. There are a couple of pulmonary veins on either side. You can see this is the left inferior pulmonary vein, right inferior pulmonary vein, and this is the left superior pulmonary vein. All pulmonary veins drain into the left atrium. The left atrium further drains into the left ventricle, and aorta arises from the left ventricle. Follow the aorta. This is the ascending aorta. Then the aortic arch, which is left sided, branches of the aortic arch, and follow the descending thoracic aorta to rule out coarctation. So the further details regarding the segmental approach towards the congenital heart diseases, including the morphology of ventricles, atria, visceral situs, and everything will be covered in the next topic. Checklist for congenital heart diseases to look for the visceral situs and heart position. Atrioventricular concordance, we say it's a concordance when the right atrium drains into the right ventricle and the left atrium drains into the left ventricle. When the aorta arises from the left ventricle and the MPA arises from the right ventricle, we call it as a ventriculo-arterial concordance. Make sure the pulmonary venous drainage is into the left atrium and the systemic venous drainage into the right atrium. Look for the interruption of IVC. Look for number of SVCs. Look for shunts like atrial septal defect and ventricular septal defect. The pulmonary artery sizes and stenosis has a good important role in the congenital heart diseases. Screen for aorta to rule out any coarctation. Coming to the tetralogy of Fallot. Embryologically, the tetralogy of Fallot happens when there is a movement of conal septum towards the right side and superiorly and anteriorly. So, when there is a movement of conal septum towards the right side, it becomes discontinuous with the rest of the interventricular septum, and then there is resultant formation of VSD. So, this is the ventricular septal defect. Because of the right side movement of the conal septum, there is a formation of pulmonary stenosis. So, because of pulmonary stenosis and due to the VSD, the right ventricle exposes to the left ventricular pressure, and then there will be a hypertrophy of right ventricular myocardium. So, RV hypertrophy is the third component, and the overriding of aorta as the another component of tetralogy of Fallot. As you can see in this images, so this is the RVOT view demonstrating the RVOT and the MPA. You can see that there is a severe narrowing at the RVOT with an flow acceleration jet during the systole, signifying that there is a pulmonary stenosis. There is also RV hypertrophy seen on these images. There is a subaortic VSD and there is a overriding of aorta. Management of tetralogy of Fallot. The definitive treatment is surgical correction of TOF. Elective surgery should be done between 4 to 12 months of age. If the patient is severely symptomatic with a severe pulmonary stenosis in early infancy or neonatal period, then also the surgical correction for TOF should be done. In case of in early infancy in a symptomatic patients, if the hypoplastic pulmonary arteries are present, then the palliation surgeries like modified BT shunt should be followed. So modified BT shunt is basically a shunt between the subclavian artery and the branch pulmonary artery. So by doing the modified BT shunt, we are ensuring that there is an increased pulmonary blood flow. It will decrease the hypoxemic episodes in the patient, and it will give the time for the pulmonary arteries to increase in their size. So when the pulmonary arteries increases in their size and they will be good enough, then the patient can undergo the correction of the top. If at the initial presentation there are good sized and confluent pulmonary arteries, then the surgical correction of top should be done. There are two prominent abnormalities in the top. One is the subaortic VSD and one is the pulmonary stenosis. So VSD, they will close it with the patch, and for the pulmonary stenosis, there will be an enlargement of RUT with either a patch repair or pulmonary conduit placement. So patch repair can be the infundibular patch or it can be a transannular patch repair. If it is a transannular patch repair or if it is a conduit repair, then they do not put a pulmonary valve during this repair. Therefore, there are chances of pulmonary regurgitation and follow-up is needed post-surgery in these patients. In the preoperative assessment, sizes of the pulmonary arteries play important role in decision whether the patient has to go for the total surgical correction for the top or the palliation surgeries like modified BT shunt. There are certain ratios like McGoon ratio, which is described as the diameter of RPA plus LPA divided by descending aorta diameter. So the RPA and LPA diameters are to be taken just before the bifurcation. So this is the RPA, this is the diameter taken just before the bifurcation. This is the LPA and this is the diameter measurement. This is the aorta dimension. So the normal McGoon's ratio is more than 2. The adequate McGoon's ratio for VSD closure, it varies from surgeon to surgeon and patient to patient. But usually the range of 1.2 to 1.6, if it is more than that, then the pulmonary arteries are supposed to be good sized. Other important factors in the preoperative assessment is the rootability of the aorta. On the cardiac MR, we see the LV, VSD, and the aorta in one plane. Then we can say that the aorta is rootable to the LV. So on this image, you can see the subaortic VSD and the overriding of aorta. So the proposed VSD patch will come and align like this. So now we can say that the aorta is routable to the LV. If on cardiac MRI we cannot see the aorta, LV and the VSD in one plane, then we can say the aorta is not routable to the LV. Second important factor is the coronary artery assessment. 5 to 12% cases of TAW, they have associated coronary artery anomalies. So not all coronary artery anomalies are significant deciding the surgical approach. However, if there is a prominent coronary artery or a branch of coronary artery which is anterior to the RVOT is considered as a significant coronary artery anomaly to decide the surgical management of TAW. As we have seen in the surgical management, we enlarge the RVOT with a patch repair. So, when we are going to put a patch, this is the anterior right ventriculotomy incision. If there is a prominent coronary artery passing anterior to the RVOT, then there will be a chances of injury to the coronary artery and subsequent complications. So, to avoid that, patient usually they are treated with the placement of pulmonary conduit. Because are the dilated aortopulmonary collaterals. If they are big in size, they have to be obliterated during the surgery of the top. If there are multiple MAPCAs and they supply the large number of lung segments, then the surgical unifocalization of MAPCAs can be done. As we see that there is an importance of pulmonary artery sizes in the management of TAW, the specialized view for the RPA and LPA can be taken. So how to take a RPA view? Take out the axial stack at the level of RPA, and then the plane of axis should be along the long axis of the RPA from its origin to its bifurcation. And when you acquire the images, you can see the entire length of RPA. Similarly, for the LPA, plane along the long axis of the LPA should be taken, and the entire length of RPA can be seen on acquisition of images. We are seeing one case, 12-year-old male, known case of TOF, post-right modified petition, came for the cardiac MR assessment. So again, according to our basic approach, we are going to see this case. So first is the innominate vein. Innominate vein drains into the SVC. There is single SVC. There is no SVC on the left side. The right-sided SVC drains into the right atrium. If I follow the right atrium inferiorly, I can see the IVC is draining into the right atrium. There is no interruption. The hepatic veins are draining into the IVC normally. Then the right atrium drains into the right ventricle. I can see some hypertrophy of the RV myocardium. I can see that there is a ventricular septal defect. So this is the RV cavity, this is the LV cavity, and this is the VSD. And from the RV, this is the RVOT. There is a muscle hypertrophy in the RVOT and there is significant narrowing. This is the MPA. MPA appears small in size and there is significant pulmonary stenosis. The MPA further bifurcates into the LPA and the RPA over here. Along with that, I am seeing a small vessel which is draining into the RPA, and if I follow it superiorly, it is coming from the subclavian artery. So it is a right modified petition and it appears patent on these images. So all pulmonary veins are draining into the left atrium. Left atrium drains into the left ventricle, and then aorta arises from the left ventricle. Follow the aorta. Aortic arch is left sided. Branching pattern is normal. And screening for the aorta, there is no evidence of coarctation. In this particular scan, we have found out that there is a subaortic VSD, there is a RV hypertrophy, there is a pulmonary stenosis. And if we see the further images, we can see that overriding of aorta across the VSD. So it is classical case of tetralogy of Fallot. So this is the three-chamber view showing the left atrium, left ventricle, and the aorta. We are seeing the LV, VSD, and the aorta in one plane. So we can say the aorta is routable to the. This is the RVOT view showing the RV. There is small sized MPA, and you can see that there is a pulmonary stenosis at valvular level. Getting the details of branch pulmonary arteries, I'm going to take the RPA view, will give me the RPA view. So in the RPA and LPA, you can take the cine images as well as high resolution black blood images. So these are high resolution black blood images. This is the MPA bifurcation. then the entire length of RPA and RPA bifurcation. Similar views for the LPA. So this is the main pulmonary artery and the LPA. So in this patient, there is subaortic VSD, there is pulmonary stenosis, RV hypertrophy, overriding of aorta. So classical case of tetralogy of Fallot. The Maguine's ratio is 1.5. The modified right BT shunt is patent. As we know, in the correction of the top patch closure of the RVOT or the RVOT conduit, and we place it without the pulmonary valve. This patient may develop pulmonary regurgitation, and due to the pulmonary regurgitation, there will be a progressive RV dilatation and dysfunction, which further increases the pulmonary regurgitation. Eventually, the patient undergo the irreversible RV dysfunction. That's why we need to intervene in between if such patients came with the help of pulmonary valve replacement surgery. Not all patients of corrected TOF require the PVR surgery. The decision of PVR surgery can be taken according to the patient's symptoms, status of RV, and status of pulmonary regurgitation. The timing of PR should be early enough to prevent irreversible RV dysfunction, and it should be late enough to decrease the number of re-interventions. So the guidelines for the PVR according to the symptoms of the patient, the severe PR, the RV dilatation, dysfunction. So in the corrected top for the follow-up, what we are going to see on cardiac MR is the functional status of the RV, including RV EDV and the ESV measurements and the ejection fraction. We have to quantify the pulmonary regurgitation. Is there any residual stenosis of the RVOT? Is there any residual stenosis of the branch pulmonary arteries? Whether the VSD patch is intact, and the QP QS ratio in cases of any residual shunts. Let us see one case. 18-year-old male underwent surgical correction of top 14 years back, came for the cardiac MR assessment. Just follow the blood flow pattern and make sure that there is no other anomaly. The systemic venous drainage into the right atrium, pulmonary venous drainage into the left atrium, atrioventricular concordance, ventriculo-arterial concordance when MP is arising from the right ventricle and aorta from the left ventricle. So this is the RVOT view. This is the RV, RVOT, and the MPA. As we can see, this is the infundibular transannular patch. There is no pulmonary valve placed. So during the diastole, you are seeing black jet coming into the RV. That is the pulmonary regurgitation. On the LVOT view, VSD patch appears intact. So this is the Q flow assessment across the aorta and MPA. So in MPA, forward flow is 109, which matches closely with the stroke volume of RV. The effective forward flow is 47 and the backward flow is 62. That becomes a regurgitation fraction of 57%. The effective forward flow in aorta is 49. So the QP by QS ratio is almost equal to 1. So there is no significant shunt in this patient. As most of the societies for the PVR, they don't give any cutoff. There are multiple papers and the recommendations for the PVR surgery. So these are the functional parameters. If more than two functional parameters are positive in a symptomatic patient, they have indicated a PVR surgery. So when indexed RV EDV is more than 150 ml per meter square, indexed RV ESV is more than 80 ml per meter square, RVF less than 47 and LVF less than 55%. Then the differential flow in RP and LPA is also important when there is a branch artery stenosis. Let's look at the another case showing the four chamber view. You can see the dilated RA, dilated RV, then the severe tricuspid regurgitation. On the LVOT view, you can see the VSD patch is intact. On the RVOT view, this is the RV, RVOT, and the FPA. You can see that there is a significant stenosis in the conduit of RVOT. So this is the case of conduit stenosis. Another similar case, you can see the VSD patch is intact. You can see some aortic regurgitation as well. On the four chamber view, RV is moderate in size. On the RVOT view, there is a significant stenosis at the level of RVOT, and there is also a pulmonary regurgitation significantly. So when we looked at the branch pulmonary arteries, RPA view showing there is no significant stenosis. RPA looks mildly dilated. On the LPA view, you can see that the LPA is small in size with unclear origin. So we have decided to do the contrast angiography in this patient, and the contrast angiography revealed that there is a severe stenosis at the origin of LPA, and the LPA is also smaller in size compared to the RPA. So again, in the corrected tetralogy of Fallot, we have to look the functional status of the RV. What is the indexed RV EDV and the indexed RV ESV measurements? The ejection fractions of RV and LV. Is there any pulmonary artery stenosis? If there is conduit stenosis or the residual RVOT stenosis, and quantify the pulmonary regurgitation. Before going to the Ebstein's anomaly, let's look at the tricuspid valve anatomy first. So tricuspid valve is the largest of all four valves. It has a three cusp or the three valve leaflets named as a septal, posterior and the anterior. The anterior valve is the longest valve circumferentially and the radially, and it is the most mobile valve leaflet. And the septal leaflet is the shortest valve in the radial dimension, and it is the least mobile leaflet. So this is the tricuspid valve. The septal leaflet of tricuspid valve attaches to the interventricular septum. It usually inserts in the septum less than 10 mm apical to the mitral valve attachment. This is the four chamber view. So you can see this is the tricuspid valve. This leaflet towards the septum is the septal leaflet, and this leaflet is the anterior leaflet. So this inferior leaflet is the posterior leaflet, and the superior leaflet is the anterior leaflet of the tricuspid valve. On the short axis images, we can see the valve leaflets of the tricuspid valve. So this is the posterior leaflet. This entire thing is the anterior leaflet, and this is the septal leaflet of tricuspid valves. So when we are dealing with the tricuspid valve pathologies, it is very important to acquire the short axis images. Ebstein's anomaly. It is an anomaly where the apical displacement of the attachment of tricuspid valve is more than 8 mm per meter square distal to the mitral valve attachment. So this is the normal attachment of mitral valve, and this is the tricuspid valve. You can see in the second image there is a apical displacement of the tricuspid valve attachment. Usually the septal and the posterior leaflet of tricuspid valve take part into the Ebstein's anomaly. The RV is divided into the two parts. One part is called as the atrialized RV, which is towards the RA, and one part is called as the functional RV. So what we are going to see in the cardiac MR in Ebstein's anomaly is the apical displacement length on cardiac MR. So you can see this is the septal leaflet of tricuspid valve, which is attached apically compared to the mitral valve. So this is the mitral valve attachment to the septum. This entire thing is the anterior leaflet of the mitral valve. So this portion of the RV becomes the atrialized RV, and this portion of the RV becomes the functional RV. Functional assessment of the RV is very important in terms of what is the size of functional RV and the atrialized RV, relation of the RVOT to ARV and FRV, QP by QS ratio if there is any shunt. Again, this is the anterior leaflet which is elongated. This is the posterior leaflet of the tricuspid valve which shows the apical attachment. And then this is the RA, atrialized RV, functional RV, and the RVOT. Let's see one case. 13-year-old female, known case of Ebstein's anomaly, came for RV assessment on cardiac MR. So the protocol for Ebstein's anomaly is the routine cardiac MR protocol, plus we acquire the short axis stacks, as we can see the valves more clearly on the short axis images. These are the axial stacks across the heart. You can see this is atrialized part RV. You can see the leftward septal bowing in this cases, which is due to the increased RV pressure. This is the four chamber view. You can see this is the septal leaflet, which has apically displaced or the attachment is apically moved. This is the attachment of mitral valve, and the elongated leaflet is the anterior leaflet of tricuspid valve. So this is the atrialized RV, this is RA, and this is the functional RV. So on the short axis images, you can see the tricuspid valve leaflet. So this entire leaflet is the anterior leaflet of the tricuspid valve. So as there is apical displacement of septal and the posterior valve, you cannot see a posterior valve. So this part is the atrialized RV and this part is the functional RV. So in the RVOT images, you can see the functional RV as well as the RVOT and then the MPA. As you can see in this RVOT view, the RVOT itself takes part in the function of the RV to propel the blood into the MPA. So it is very important to include the RVOT as a part of functional RV when we are assessing it. So the functional RV also includes the volume of the RVOT. So the size of the functional RV is 50 ml per meter square along with the RVOT. The ejection fraction is good, 57%. The atrialized RV is 60 ml per meter square. So it is very important for us to quantify this tricuspid regurgitation associated with Ebstein's anomaly. So tricuspid regurgitation gives by the stroke volume of the functional RV minus stroke volume of the MPA. So stroke volume of functional RV we calculate using the cinestat, and the stroke volume of MPA we calculate using the phase contrast imaging. Learning points. What is the basic approach towards the congenital heart diseases? As we know, cardiac MR is gold standard for LV and RV functional assessment. Phase contrast imaging is a very important tool for the flow and the shunt quantification as well as the quantification of tricuspid regurgitation in Ebstein's anomaly. In corrected talk, CMR plays a very important role in follow-up of this patient and if there is any indication for the pulmonary valve replacement. In Ebstein's anomaly, cardiac MR plays a very important role in calculating what is the size of the functional RV. So, if the size of functional RV in the Ebstein's anomaly is good enough, then patient can undergo corrective surgery for the Ebstein's anomaly. Thank you very much.